Well, welcome to Leading Rural Healthcare, the podcast where we talk with leaders shaping the future of healthcare in rural communities. I'm your host, Brendan Hurley, and today's episode brings the conversation inside the real decisions that keep a rural hospital running. Joining us is Steve Henson, who's the CEO of St. Genevieve County Memorial Hospital, which is a county-owned critical access hospital that also includes 6 primary clinics offering primary and specialty care and serves southeast Missouri and the surrounding region. Before taking the helm at St. Genevieve in 2025, Steve spent the better part of 2 decades leading hospitals and health systems across Arkansas and Tennessee. His accomplishments include implementing cost-saving initiatives, and he drove EBITDA decreases, minimizing staff turnover through effective retention strategies, achieving highest ever patient and staff satisfaction scores, and new participation and satisfaction benchmarks, all the while increasing coworker satisfaction. He also holds the Rural Hospital CEO certification from the National Rural Health Association. So Steve's no stranger to the hardest calls that you have to make in this business, from restructuring services, which I know we're going to talk about, to leading his team through change. And he's here to talk openly about all of it. So Steve, welcome to Leading Rural Healthcare. I'm so glad to have you with us.
Thank you, Brendan. I appreciate that.
Yeah. Well, tell us a little bit about your hospital. I know you're just now getting 1 year under your belt, right? So maybe you can give me the annual report. But tell us what you offer, the communities you serve. I know again, you're past the honeymoon period, so lay it on
Yeah.
me.
I've been here 1 year and 2 days today. It's been a great first year. But about St. Genevieve County Memorial Hospital, we're a critical access hospital, as you mentioned, county owned. Um, as you would typically find in critical access hospitals, we've got 25 beds. We have a number of services, though, that you don't find in all critical access hospitals. We have a fairly robust orthopedic program. We're doing total hip, total knee, and total shoulder replacements here. And then we're also, as I understand it, the smallest hospital in the nation with a cancer center. We're doing chemo here, and we don't do radiation here. But we're doing basically everything else, and that's a bit unusual for me. I've been part of a hospital that had a cancer center, but it was a 300 plus bed hospital years ago.
Wow, that is very unique. I mean, you're serving a broad area, right? I mean, I just doing a little research, nearly 10 counties that you're drawing from. So I imagine those services are vital in 2 different states, right? Missouri and
Well, so yes and no. So I had the same thought when I came here. I'm used to coming into a hospital, dropping a pin on it, and going out so many tens of miles in a diameter and saying, this is probably our primary catchment area. And that has always been the case. And my first day here, I made that statement, and the CFO and the CNO I was talking to said, well, that's not really the case here. We're really a half moon. And I said, a half moon, why is that? And they said, Mississippi River. So from where we're sitting, you either have to go north to get to a bridge, or you have to go south to get to a bridge. And so when you do see a patient with a zip code from Illinois, really what it is somebody's come over here for a festival in St. Genevieve, which there are many, many each year, and they wound up needing some emergency room services. So really, our catchment area is a half moon day in and day out. And
interesting.
it's the
Well,
it's the only time I've seen that in my career.
yeah, well, I mean that is very unique. Well, I mean, not to mention just going back to what you'd shared. I mean, what do you think attributes to having some of those unique service lines there at that hospital that to be frank, is unique than what you're used to seeing at a critical access?
I can tell you when it comes to the cancer center, my understanding of the history there is there was an individual patient in the community that had to have cancer care some years ago, had to go out of town and drive for it, and had a good outcome, as I understand it. But she came back and she said, you know what? I don't want to have to drive out of town for cancer care in the future, and I don't want other people to have to do that. The hospital said, hey, that's great, but we don't have the building space for it. We don't have the equipment. She being the patient really got behind a grassroots effort. The community pulled together and funded the build out of the cancer center and furnished the equipment that went with it. So it was really a case of the community coming together and saying, we want this. The hospital said, hey, we'll be glad to staff it and operate it, but we need help with this, and they funded the build out. If you're when you come and you stop by one day, I'll take you in the hallway or outside the hallway. There's a huge marble plaque that has the name of the people who really stepped up from the community to make that happen.
Wow, that
Yeah.
is so fantastic. And I know we're going to talk, at least I hope to talk a little bit about, you know, rural hospital perception, right? And the price a patient pays when they come to the counter. And so it's so cool to hear stories like that where, just based on what you've shared, the community is engaged in a higher purpose. The community knows how important this hospital is and that it can't always stand on its own 2 feet, right?
Yeah.
Sometimes there's a little support needed.
Absolutely, absolutely. And when it comes to the orthopedic program, we've got two really great surgeons that rotate through here weekly from BJC. They come out of the Farmington area, but they've been coming here for years before I got here. Matter of fact, one of them's going to do a total right knee on me come September 3rd.
All right.
Nice thing is I don't have to travel for it. I'll just walk down the hall, so to speak.
You get the insider undercover boss, right?
There you go. Yeah, I haven't thought about it that way, but yeah, you're right.
Yeah. Well, you didn't take, I mean, so let's focus on you a little bit. I mean, you didn't take the typical route to the hospital corner office, right? I mean, you started as a registered paramedic, moved through, emergency management, and then earned a law degree, right? So,
Yeah.
walk us through that path and what each stop really taught you as still use it in your capacity as CEO.
So years ago, I'm 23 years old at the time. I was dating a young lady who was working for the local ambulance service. That ambulance service had been a county-owned ambulance service. It had gotten out of the county got out of the business, sold it to a private individual, and a lot of the old county employees didn't stay on. And the new owner had to employ a number of people that were under the age of 23. And why 23 is important here is because his insurance at the time said you had to be 23 to drive an ambulance. So, long story short, I'm dating this girl, and she approaches me one day and says, the ambulance manager wants to know if on your days off from the job I was doing at the time, you would be willing to drive the ambulance. Now, keep in mind, I'm 23 years old and I'm still a young man. And my first thought, just to be quite frank, was, okay, let me get this right. You're wanting to pay me to drive fast. Yeah, I think I will do that. And so that's really how I got into healthcare. I actually started as a legitimate ambulance driver. Now, I only did that for about 2 weeks, and we were called out. I had to take an ambulance out with the crew to a really bad scene on interstate. A couple of diesel trucks, a van full of family. One of the diesel trucks had caught fire. There was entrapment. We wound up having to bring in a helicopter for some of the patients. And I knew how to do absolutely nothing but drive the ambulance. So that started my education. Ultimately wound up being a paramedic for a number of years. Became a director of the paramedic service for St. Joseph's, which at the time was a Mercy hospital in Hot Springs, Arkansas. And during that time, as a director, I began developing an interest in increasing my education and potentially getting into hospital administration. And at the time, I'm having a conversation and I'm looking at, what's the quickest path with my existing education in order to get the education I need to apply to law school. And emergency management was the great fit. It was closest path. I got a lot of credit for my existing education at the time. And so I did ultimately go to law school. There's actually a story of how I got there. And I'll share that with you right quick because people have found it interesting over the years. I'm the director of the ambulance service for St. Joseph's. We're covering 5 counties at the time out of Hot Springs. And I'm sitting in the office of one of my mentors, a vice president of human resources named Ray Pelton. And Ray's having that HR conversation with me
Yep.
about, where do you see yourself in 5 years, in 10 years? And he
Right.
and he asked me the question, he said, what would you like to do? And the way I answered the question, I said, well, Ray, I would have liked to have gone to law school. And when I said that, he just sits back and his eyes get big. And he says, you want to be a lawyer? And I said, no. I said, I don't want to hang out a shingle and practice law. I want to be a hospital administrator. He said, well, why law school? He said, why not go get your MHA? I said, well, Mercy in those days at that facility was pretty good with directors about providing them with business education on how healthcare works. I said, I don't think I'd actually get anything from the school other than the diploma, but I do think I get something from law school. And he said, well, what is that? And I said, well, law school, from my perspective, really teaches you two major things that I was interested in. Teaches you how to think about a problem from a 360-degree perspective, and it teaches you how to do really in-depth research. And I said, I think those two things would be very beneficial. And so we're having this conversation, and Ray said, well, why don't you go to law school? And I said, Ray, I've got a young family. I have to work full time. I'd have to go at night. Night law school is 4 years. I said, even if I applied this year and got accepted, I'd be 40 years old before I graduated law school. And he pulls an old HR trick on me. I didn't know at the time. I've used it many times since, but he nods his head. He kind of pushes back away from the table and he goes, yeah, that's too bad. And I said, yeah. I said, but it's just life. He said, well, let me ask you a question. I said, all right. He said, you're going to be 40 anyway. And I said, well, yes. He said, you want to be a 40-year-old paramedic or 40-year-old lawyer? And the rest is history.
Wow.
I applied, took the LSAT, got accepted to law school that year, and the rest is history. So
Oh my gosh. That is
now,
that is a,
what? Go ahead.
no, I mean that's just incredible. Finish your thought, please.
Yeah. Well, and so you also asked, what do I take from those areas that I bring with me here? From my paramedic days, I one do not get intimidated by anything. I mean, almost no situation. And I'll give you a specific example there. When I was in law school, my first year of law school, there was a professor who had a reputation for being pretty brutal with first year students just on the grilling questions. And he singled me out one night and he starts asking questions. And I'm just being very calm and
Yep.
frank with him. And at a point after about the fourth or fifth question, he said, Mr. Henson, you do not seem to be intimidated by me. And I said, no, sir. And he said, perhaps you have not heard of my reputation. I said, yes, sir, I have heard of your reputation. He said, well, do you mind telling me why you're not intimidated by me? And I said, you know, I've had children die in my arms, speaking figuratively as a paramedic. I said, I've had children die in my arms. There's not really anything you can say or do to me that's going to intimidate me. And he nodded his head and he said, I believe you are correct. Yeah.
My gosh.
Yeah. But so I get that from my paramedic days. I don't suffer from analysis paralysis. I'm very comfortable taking information. I want good information. I don't want to just shoot in the dark, but taking what information we have available and start solving a problem at that point and get more information and modify the plan as we go. That also comes from my paramedic days.
Yeah.
The education on emergency management certainly taught me that not only do you need a plan, but you need a redundancy plan. The military has a saying, one is none and two is one. I carry that with me as well. And then in law school was hugely beneficial. I mean, between the contracts, the employment issues, there's actually not anywhere near as much medical negligence as the public would probably believe there was. But it has been hugely beneficial. It also helped me not see the world quite as black and white as I did when I was a younger and before I went to law school. I realized that really the world is just all different shades of gray.
Yeah. Well, I'd just be curious. I mean, you've got such great experience rooted in being a paramedic and your legal background. I mean, being a paramedic, right? You triage, you're acting fast, thinking on your feet, and then even as you said, doing in-depth research and looking at a problem from all angles and being more methodical. I mean, how do you, when you're making decisions from this seat, right? I'm sure you're presented with all kinds. Ones you have to make very quickly with the information you have at hand, and other times when you have to be methodical. And I can only imagine how that background has helped propel you in the role you're in today.
Absolutely, it has. And it was particularly useful in this one. I arrived here on June 23rd last year, and the organization had been suffering some significant financial challenges for about 2.5 years. And we were on a pretty tight timeline with some bond covenants. And
Yep.
June 23rd, I arrived here, and September 9th, we had a board approved restructure plan in place, and I pulled the trigger on September 9th. That's a pretty quick turnaround. In fact, it's the fastest turnaround I've done in my career.
Wow. Well, I know we're going to talk a little bit about that because you didn't waste any time getting to work right when you showed up in St. Genevieve. But talk about a little bit just you personally, right? What pulled you toward rural health in a rural healthcare setting, which you've been in multiple times now, right?
Right.
And
Yeah.
developed a career in rather than an urban setting or a large urban hospital, city hospital.
So it's really an easy, simple answer for me, and it's the people, and more to the point, Brandon, it's the connection with the people. And let me give you a very recent example. So in the last few weeks, I traveled to a larger hospital to meet with one of my peers about some ways we might could partner with some specialists. And when I walked into the lobby of that hospital, which is a much larger hospital, there was the volunteer gentleman was sitting at the desk like they do in so many hospitals, including ours. And I walked up to the desk and I didn't say I'm here to see the CEO or I have an appointment with the CEO. I just said I'm here to see, and I called the gentleman by name, the CEO by name. And the guy at the front desk looks at me funny. He said, "Well, who is that? What department are they in?" And so I smiled a little bit and I said, "You must be relatively new here." And he said, "Well, no, I've been a volunteer here for 8 years." And I said, "Oh," and I said the gentleman's name again, and I said, "He's the CEO of the hospital." Oh, okay. Well, you probably want administration then. And so I say that if you
Yeah.
walk into this
Right.
hospital or virtually any other mid-sized to small rural hospitals that I've helped over the
Right.
years, you would be hard pressed to find anybody in any department or any clinic that can't tell you who I am. And odds are I've had more than one conversation with them.
Right.
And most of the time, it's not even a business conversation. It's, "Hey, I understand you've got kids that's playing baseball this weekend or last weekend. How'd the game go?"
Yeah.
Just making the connections with the people who are doing the job.
Yeah.
That's really what drives me and attracts me to this particular venue.
Well, and I mean, I think that plays just the way you've described that plays into what I can tell your leadership style is, right? I mean, talking about getting, we'll talk to other CEOs I've had on the program about feedback loops and what they do to get engaged with their population and what you've probably had to do to get engaged very, very quickly, not just with your own employee population, but with the community. Talk a little bit about that. I like what you do to shore those relationships up quickly and create relationships where they didn't exist before.
You just simply have to make yourself available, and you as the CEO, it's your responsibility, from my viewpoint, to go out and build those relationships. I've met some of my peers over the years, and as we've said and talked, it was obvious to me that some of them had the position of, well, I'm the CEO. People should come to me and develop a relationship with me. No, that's from my perspective, that's absolutely the wrong mindset. Now, again, rural hospitals, smaller hospitals, you can do that in. Larger hospitals, if you're CEO of a 500 bed hospital, can you really do that? Probably not, but that's why I like this venue. But I've met some of my peers over the years, Brendan, that they were in critical access hospitals. Well, I'll give you another specific example. I like to use examples, by the
Yeah.
way. A critical access hospital I helped back in 2017. When I first got there, I made the staff nervous because every morning when I came to the hospital, I would walk through the hospital. I'd go through the ER. I'd go over into the surgery area. I'd walk through the nurses station where the med surg station was, the inpatient beds, and I could tell that it was making the staff uncomfortable. And finally, after the first week, I asked my assistant Brenda. I said, "Brenda, what's going on here?" And she said, "Well, they're just not used to it." And I said, "What do you mean?" She said, "Well, the CEO that was here before you probably didn't go to the hospital maybe three times in all the years he was here." And so I didn't stop that. I kept doing that. And I was about 2 months, Brendan, into that particular job. And there was something that came up that morning that required my undivided attention. And I did not make my early morning rounds that morning. And the nurses from the med surg unit actually called
Called
Brenda
to make
about
sure.
10 o'clock and said, "Where is Steve at? He hadn't been by
Is he
today. Is he
okay?
okay?"
Yeah.
Yeah, I mean, I just use that as an example of you've got to work on making that connection with your staff. And it will really get you down the road in a lot of other areas that we're probably going to talk about this
Yeah.
afternoon.
Well, I mean, we can go there now. I alluded to just metrics you've had around. Not that we need to boil everything down to a metric, right? But
Mhm.
when you think of the lagging indicator of doing things like that, and you pair that with retention, right, and culture,
Yeah.
and all of those things. I have no idea what you were walking into last June, but talk a little bit about your experience in those types of initiatives on their own, but also just the way you operate as a leader that attributes to that top-down mentality of how culture is created, and again, the benefit you have in a number of areas, but namely retention and employee satisfaction and some of those things that you've had, accolades, given to you or the systems you've been a part of as a result.
Again, it really comes down to you, the CEO, taking the initiative to go out and build the relationships. You've got to be open, honest, genuine. I have I'll share this with you. I have an open door policy everywhere I've been, meaning that if I'm literally not doing something like talking with you right now, my door is open and anybody in the organization can come knock on the door and say, "Hey, Steve, do you have a few minutes?" In fact, I have a customer service class that I've been teaching since 2006, and I taught that first class here up at our Bloomsdale clinic, and that was about I think 7:30 in the morning class. It's about 4 o'clock that same afternoon, and I'm sitting here in my office, and there's a on my door, and there's a lady that I recognize from the Bloomsdale clinic, and she said, "Mr. Henson, do you have a few minutes?" I said, "Sure, come on in." So we sat at the table in my office, and we literally talked for about 15 minutes, and I've realized she hasn't asked me for anything, which is strange. Most people come to see me because they need something or have a concern. And she hadn't asked me for anything. And I said, I'm not meaning to interrupt. I said, but is there something you're wanting this afternoon? You haven't asked me for anything. She said, "No, sir, you said you had an open door policy. I just seen if it was true." And I said, "Well, apparently it is."
Yeah. Oh,
But
that
but
is
it
great.
but you've got to lead from the front. You've got to work on developing those relationships, and there are key people in the organization that you definitely have to build the relationship with if you want to make really robust changes, and especially if you want to do it in a short order of time. And those people, Brendan, are the informal leaders that exist in every single organization. So, I would challenge the hospital CEOs, my peers out there, to look around our organization and figure out who is it when a memo is released, when a board update or a CEO update is released, when there's going to be a new direction taken. Pay attention to who it is that the staff go to that's not a manager, not a supervisor, not administration. Who are they going to and saying, "Hey, Steve has said this. What do you think?" These unofficial leaders exist in every single organization. It behooves you to identify them and for you to reach out and build a relationship with them. Then you don't have to have a friendly relationship with them. Some
Right.
of them may not necessarily want to have a friendly relationship with administration. However, what you have to do is have a relationship where you can go and have a comprehensive conversation with them so that when you do have to pull some hard levers, they at least have the information
Right.
necessary so that when the staff comes to them, and they surely will, they can at least talk legitimately about it. Whether they agree with it or not, they at least have the information.
Right.
So that's kind of one of the no longer secrets that I keep in my pocket, so to speak. Early on, whenever I go somewhere, I identify who are the informal leaders, and I make a point to show up in their department and spend just a little bit of extra time with them, working on building that relationship.
Right. I may not agree, but I understand. I
Yep,
understand where you're coming
absolutely.
from. Creating those champions, maybe we could call them within the organization.
And well, you could say that absolutely.
Yeah. Well, for any listener we've been talking a lot about critical access hospitals, smaller hospitals, the culture there. What does it mean to be a critical access hospital? I mean, why does that designation matter for a town like St. Genevieve, both
So,
financially and just in general?
yeah, so I'm going to answer your question, but I'm going to start by prefacing it by saying it's not it doesn't make as big a difference today as it did 10 or 20 years ago. And I'm going to get to
Okay.
that. So critical access hospitals, when they were first set up, were a vehicle that where CMS would pay you your cost on your cost base. And it was a way of CMS and the government trying to help prop up rural hospitals and make them more financially solvent. You have a couple of vehicles out there. Your clinics can get rural health clinic designations, which means CMS reimburses those clinics a bit better than they do clinics in an urban setting. And then on the cost report, at the end of the year, when the auditors and your CFO true it up, and you look at what were our actual costs versus what were our revenues, in past years, there was potential windfalls in money coming in. You can think of it. I'll use the analogy. It's not a great match, but somewhat paying in too much taxes through the year, and then at the end of the year getting some money back on your taxes. Now, doesn't always work that way. If your cost report shows that you're not going to wind up getting a windfall of $746,000 this year, you actually owe $250,000. That can happen too. You just have to really be thoughtful with your strategy about where your costs are and in what department bucket, so to speak, where your Medicare, particularly where your Medicare patients were. Now, I say all that to say this: it's not as relevant, and I think it's even going to be less relevant in the future. Now, the rural health clinic designation for your clinics is still very relevant. But what has happened is if you go back even here, if you go back 16 years ago, our payer mix for Medicare was about 50%.
Mm,
It's still 50% today.
really?
Well, if you're 50% Medicare, 16 years ago, and it's traditional Medicare, that all applies towards the cost report calculation. Now, let's fast forward to last year. Last year, for the first time, this organization, we're still 50% Medicare payer mix, but for the first time last year, we were 24.6% traditional Medicare and 25.4% managed Medicare
Yep.
products. It's still Medicare. However,
Sure.
managed Medicare products have zero impact or influence on your cost report. So what I essentially just told you is
Mhm.
if you think that of the 100% benefit we got from Medicare in the past for our cost report, last year we got a little bit less than half because managed Medicare products don't apply to the cost report.
Wow.
So from that perspective, I've already had conversations with the board. We need to be thinking about what does this mean because the trend of managed Medicare is not going to go away. I think it's going to
Yep.
continue to get larger, and it's probably going to force us to make some decisions at a point in the future.
Well, I'd be curious. I mean, as you may know, I didn't share, but I'm in the insurance industry, right? I'm an insurance consultant, work with hospitals on their employer strategy around medical insurance. But I'm just close enough to the Medicare Advantage, we'll call it situation, to hear enough about hospital CEOs, CFOs, especially in rural areas, talking more and more about, do we contract? Do we allow this carrier to enter our region? So I'd be curious, as you make those comments, are those the sort of decisions that you think are on the horizon in determining, who you're going to allow, right, to partner with the hospital in terms of in network, out of network, and let it cannibalize,
Yeah, there. So to get to your point you're making, those conversations are taking place pretty regularly across the scope of the or across the scope of the country with my peers and organizations our size. Here's my viewpoint on that. So you say, you know what, we're not going to contract with you to provide this. We're not going to let you here. We're not going to be on your list of payers, so to speak. The people in your community are still going to gravitate to it. And because let's be quite frank, what people are seeing these days is traditional Medicare costs me X, a Medicare Advantage plan costs me Y, a smaller amount. They perhaps do or don't understand that managed Medicare is not exactly traditional Medicare. What they know is the cost is less. They're going to go with it, and you're going to wind up losing them anyway.
Right.
So, it's kind of, from my perspective, it's kind of cutting your nose off to spite your face.
Right. Right.
That's just the reality on the ground.
Well, and again, yeah, it kind of goes back. We've heard some healthcare leaders talking about the importance of education, right? Even if it's not their own population, but just in their communities, about the differences and making sure you have an unbiased approach to. I mean, one can work well for both individuals, right? Two different
Sure.
kinds of individuals. So, but you've said I kind of want to talk about uh, having rural health care in terms of relevancy in rural areas, just having that access. You've said that it's essential, and of course I know that to be the case. But make that case to the leaders listening. I mean, what does a community actually lose when it loses its hospital beyond the beds?
It's easy to think of it in terms, if you're on the outside looking in as well, we lost our hospital, we have to drive somewhere else. So I'll answer your question, but let me ask you to think of it this way. What does a community lose if it loses a major employer? So let's say a community has a large manufacturing company that's provided hundreds of jobs to a small rural community, and all of a sudden that manufacturing company says, you know what, we're going overseas. The jobs just went away. For a rural hospital, when you look in a rural community, those hospitals are more often than not
Lord.
in employing a large number of the community. The jobs usually pay, especially these days, pay very well. These are people that even if you're a not-for-profit organization that's not necessarily paying the local taxes, your employees are probably paying personal and or sales taxes in the community. They're spending their money in the community. I mean, it's from my perspective, you're losing an economic engine of the community. And sometimes communities don't look at it that way. They think, well, it's the hospital. No, it's an economic engine. It's very similar to losing a major manufacturing employer when it
Yeah.
comes to the jobs and what that can mean to a community.
Well, yeah. I mean, just talk to any economic development director who is tasked with bringing new business, new vitality to a community, right? And the first
Yeah,
thing any large employer or small is going to ask is, what do the schools look like, and what are the hospital? What is there a hospital?
exactly. Yeah, exactly. How good are the schools? How good is the health care?
Yeah. Yep.
Yeah.
Well, we touched on it earlier in terms of how you wanted to hit this head on. So let's get at it. I mean, the public sees what they're charged, right, and assumes the hospital is profitable, regardless of what the actual case scenario is. So for the community members who might be listening, where does that money actually go, and why is the bill so different from what you collect?
So we could probably spend an hour and a half just on talking on this topic, but I will try
Yeah.
to keep it succinct. Um, Healthcare is pretty unique in that for the most part, there's a third party that's paying the bills. I mean, some people don't have insurance coverage, and they're it's no different from them than they're if they're going to a store to buy something. But most people have a third party that's providing the payments. And yes, our hospital charges expensive. Yes, they are. I'm not going to sit here and say that they're not. If you come in here and have an MRI, depending on the type of MRI you're having, you could easily get a bill for $1,000+ Is the hospital going to collect that money? The answer is no. Hospitals don't get paid on what their charges are as a general rule. In fact, they get paid a surprisingly small amount of what those charges are. And case in point, we have Medicare and Medicaid. Medicare and Medicaid tell hospitals from year to year, this is what we're going to pay you. Have a nice day.
Right.
There's no negotiation with that. If you're a rural hospital, do you really have the power to negotiate with a United Healthcare, a Blue Cross Blue Shield, and Aetna? The answer is no. You really don't. It's not that you can't have the conversations, but they're going to pay you a percentage of your charges. Some pay better than others, but nobody's paying 100%. So, most rural hospitals, let's just get this out there on the table, and let's just keep it in Missouri, although this applies to the entire nation. Of the 58 rural hospitals here in Missouri today, half of those are operating in the negative. They're losing money every year, year after year. Is that sustainable? No, it's not. In the nation right now, there are 720 hospitals that are classified as at risk of closing. You look at the number of hospitals that have closed in the last 10, 15 years, it's a pretty shocking number. Now, where do I think the money is? And I would just challenge people and the patients, so to speak, to look at where the money is. Look at where the margins are. Hospital margins, even a good hospital margin, is about 2%. with a lot of hospitals operating at -2%. And here we're talking about rural hospitals. Are there some hospitals out there that operate at higher margins? Sure. Very few. What's the margins of, say, I don't know, pharmaceutical companies?
Oh yeah.
And I'm glad that pharmaceutical companies in recent years have made record profits. But I would just tell you that if you wanted to really understand the medical industry in the nation and where the money really is or isn't, look at the margins of
Right.
the players, and
Yeah.
you'll see really clearly where the money is or is not. Now, where does the money go? Your other question was for hospitals, where does that money go? Um, a little over half of it, somewhere depending on your organization, 52 to as much as 56% of it goes to salaries, wages, and benefits. Most of the organization's expenses are in labor. It goes back to what I was saying a while ago. Good paying jobs, they're paying their taxes, and spending their money in the communities. It's an economic engine. Another big piece of it, especially this year, is going to our supply budget, and it's the pharmacy costs that are driving that up. Pharmacy costs have really gone up significantly in the last 2 years. And so you're at 52%, and then you add your supply cost in there, all of a sudden you're out at 75+% of the money that you're spending day in and day out just to operate the hospital. I
Yeah.
mean, and I don't think a lot of people understand too how expensive it is to operate even a rural hospital. And I'll give you an example. This was our last month in May. By the way, it was the best operating cost we've had going back at least 2.5 years, as far back as I've mapped it. But in May, it cost us $211,088 a day to operate the hospital. That's how much we were paying out in salaries, wages, and benefits, in supplies, and in electricity. That's how much a day it cost. And that number, we were able to bring that number down from where we were a year ago. But that's still, when I've shared that with some people in the community, like, I had no idea that it cost that much a day to operate a hospital. Absolutely, it does.
Yeah. Well, I mean, the costs are everywhere. And you mentioned pharmacy costs. I mean, that's one we're talking about. Not everyone realizes you can't just pass that along. I mean, is St. Genevieve a 340B covered entity?
We are, yes.
Yeah. Talk to me a little bit about, what's going on there, right? I mean, we talk about critical access, the benefits that has,
Yeah.
being 340B and the benefits you're mandated to get from drug manufacturers, right?
Yeah.
There's a lot going on
So
there.
Yeah, so 340B, especially in the last 2 years, has been very favorable for us to help us try to balance the books. Now, if you really, dig into what's going on at the federal level, what you'll find is the pharmaceutical industry is lobbying very hard at the federal level to really choke that down and throttle it down, and what essentially take money away from the hospital. So, we're already having internal conversations about what does that mean for us if that happens. And it would it be devastating to us? Probably not at this point in time. But would it be painful to us? The answer is absolutely yes, because
Yeah.
we would have to find somewhere else to help balance the books.
Yeah. Well, you talk about, the areas where for those listening, community members and others trying to figure out where's the money going, right? And your comment of, well, look where the margin is. And so I'm oftentimes, even in our business, where we're talking a lot with employers about the large carriers and the consolidation that's been going on since the Affordable Care Act, right? There was a McKinsey report that came out that really showed, I mean, because they're all publicly traded companies, right? So you can see
Right.
where the fat is,
Yeah.
and Jeff Bezos, say what you will about him. I mean, the quote of, find out where their margin is, and that's our opportunity, right? And that's
Yeah.
kind of how I feel like I've heard, hospitals talk about their opportunity, just organizations talk about their opportunity, especially as it relates to, of course, my world and the benefits world. But that is sobering to hit $211,000 a day. Even for me to hear that, I think that changes the perspective, as you mentioned, when you share that with your community members. Now, I mean, for the other CEOs listening, talk about the real pressure points, right? outline some of them. Payer mix reimbursement that lands below cost, right? The fixed expense of keeping the doors open 24/7 at that daily rate. I mean,
Yeah.
what's squeezing rural margins the hardest right now?
From my perspective, it's the salary, wages, and benefits, and
Yeah.
particularly it's the salaries. I mean, there's and from my perspective, I've been doing this 38 years. There's healthcare pre-COVID, and there's
Mm,
healthcare post March of 2020, post-COVID, so to speak. Did COVID cause everything? The answer is no. But did salaries explode in healthcare on the other side of COVID? The answer is yes. I mean, when all of a sudden hospitals started having to compete with travelers,
mm,
especially, I'll give you an example. A person that's very close to my family, registered nurse, ER and ICU nurse at the time, COVID hit. She signed up as a traveler and left. She was in Arkansas, left Arkansas and went to Dallas and worked for about a year and a half as an ICU nurse in a COVID unit, um, and came back and basically retired. She was being paid huge money to go down there and do that. And when that happened, a lot of other people started to jump
right.
on the bandwagon, and then you start having to pay higher rates to try to retain people in your area. Is traveling for everybody? The answer is no. And do a lot of people get burnt out doing it? The answer is yes. But really, we saw as healthcare organizations, the salaries really start to grow after COVID hit. And they've really not been reined back in
Right.
yet, so to speak. And once as the saying goes, once the horse is out of the barn, I do think that there's probably a some benefit down the road with some things that I think are going to happen, but that's still a few years away.
Yeah. Well, there certainly hasn't been a reset, and I've heard and felt that, even though some of the staffing opportunities have gone down. Right, there's more full time W-2 employed by the hospital. Going on. It's to your point. Yeah, that's what we're hearing. Is just it probably won't reset fully, and so I do want to talk about something earlier in your career when you were at Bradley Medical Center in Arkansas. Just another initiative you rolled out. I mean, you reversed, what was it, a 5-year decline in volumes and built a hospitalist program that cut transfers and added more than 600,000 to the bottom line. I mean, what from that turnaround do you carry into St. Genevieve when you mentioned even earlier in this conversation, right? You were staring down maybe not a turnaround in the same way, but financial difficulties and headwinds that you had to work at reversing or softening.
Yeah, so it those were two actually vastly different situations. So Bradley County, I'll give you the example. I mean, that area, it was in the primary service area. That population had peaked in like 1975 and had been in decline since that period of time. There were some local doctors, great doctors, that were, burning the midnight oil, so to speak, trying to see the patients in their clinics, trying to do some work in the hospital. They were coming over doing some GI work in the mornings in the surgery department. And there was a tendency, we didn't have a hospitals program. They were having to see their own patients in the hospital. We didn't have a hospitals program. There was a tendency to say, well, this patient's sick. Go ahead and transfer them. Go ahead and transfer them. Go ahead and transfer them. And I realized pretty quickly, if we had a hospitals program, is it going to cost us more money operating wise? The answer is yes. But are we going to retain more patients from our ER and be able to admit them and thereby get the revenue downstream from it and offset that increased expense? And the answer was very clearly yes. Here, when I got here, there was already a hospitalist program. The population here is very stable. It is certainly not in decline at all. And so, really, to answer your question, was I able to bring anything from that experience, 2017, to this one in 2025? Really just to reinforce what I already thought, that it's never cookie cutter, or cookbook,
Right.
um, administrative work. Every organization is going to be a little bit different. Those two were really somewhat polar opposite.
Yeah.
The
Well,
financial challenges here were a very different set of challenges than what they had there.
Right. Well, we alluded to some of those financial challenges based just to service lines, and I'm making an assumption here, but I mean, at the end of 2025, you closed the labor and delivery department and home health in the same sort of restructuring that went on. So, I mean, for a lot of leaders listening, I mean, this is certainly a decision they dread the most, but one that I'm sure you did in-depth research, were methodical about, and I would just love to know, for our listeners as well, take us inside how you arrived there and how that was the right decision for St. Genevieve.
You know, got here thinking 15, I said, okay, I want to where the margin. I want to see where we were making a little bit of margin, where we were breaking even, and where we were bleeding money, if you will, at the time. Um, Labor delivery came up to be the biggest one that was losing revenues. Home health was also losing revenues. That I think it was the number two. Historically, when everything else is working well for a hospital, you can have loss leaders. I mean, labor and delivery for a very long time now has not been a profit center at all. But you can have loss leaders if you're making it up elsewhere. Problem is, over time, as you lose your margins in other areas, all of a sudden you can't afford to lose $1 million a year providing labor delivery services. Now, that in and of itself is not the deciding factor. That's just where I started. Once I figured out, okay, here's where our loss leaders really are. What I want to know is in this order. I want to know how many deliveries we've done a year for the previous 5 years. And I suspect if some of my peers do this trend, they'll see that it's been trending down. But I want to know how many deliveries we've done a year in this hospital for the last 5 years. Get that information. I want to know the zip codes of the parents of those deliveries. So I overlaid the zip codes with it, and what zip codes were coming out of St. John County, because after all, we're a county hospital versus other counties. And then when I had that, I went to the health department, and they're always about a year behind. But I went to the health department and I said, I want to know how many babies were born to St. John County residents each year for the last 5 years. Again, they couldn't give me the most recent year. And then I overlaid that. And here's the picture I saw, Brandon. We do have a decline in births. That didn't surprise me. It's really going on across the nation right now in recent years. The majority of our births were not coming out of a St. John County zip code. They were coming out of two other counties adjacent to us, but not St. Genevieve County. And of the births that were actually occurring in St. Genevieve County, we were capturing less than 30% of them. I think it was, I'd have to look at the numbers again, but it was like 20, maybe 6%, barely over a quarter of the births that actually occurred in St. John County during those years were happening in our hospital. Now, that also doesn't surprise me. And here's the reason why. And I know my peers in rural healthcare is going to nod their heads whenever they actually hear this. People who can, for a very long time now, will choose to have their babies where there is an ICU upstairs and not 30, 40, or 50 miles away, and an NICU specifically. Do most births result in a baby needing an NICU? The answer is no. There's only a percentage of them that need that. But for people who think about it, they're going to choose to have their babies where there's an NICU upstairs in the hospital, again, and not 30, 40, or 50 miles away. And that's what we found going on here. So, I painted that picture. I met with the board, obviously, over a number of meetings, but it was very clear we're losing this huge amount of money delivering babies for other counties. Right. That's not a good steward of our county resources. Right. Now, if you're not a county hospital, it changes your analysis a little bit, but I would always go at it in that formula, if you will. Right. What's your trend line for at least the last 5 years? Where are the zip codes of the babies coming from? And then how many are actually being born to zip codes in your service area? And when you find significant disparities like we did, it really informs your decision.
Yeah. Well, really, those births coming from families outside the county, you touched on it without saying it explicitly, right? But every hospital has a different guiding North Star, a different mission. They're nonprofits, county-owned, city-owned, private. And you have to abide by that, right? That's where you're carrying out your organization's mission. I mean, I will say, these decisions while I've not been at certainly not been at the helm of when they've been made, but they live or die on how they're communicated, especially an emotional one like labor and delivery. I mean, walk us through your approach, who heard it first, how you sequenced staff versus the public, and really what you were trying to protect in that rollout. I mean, you probably had enough time now to see that unfold.
Yeah, so I will share with you, you're absolutely right in what you just inferred. Um, Cutting labor and delivery is probably the most community-wide emotional decision you can possibly make. How many people have walked up to me when it became public knowledge, I was born in that hospital. My children were born in that hospital. One of my grandchildren was born in that hospital. It's an incredibly emotional piece. Now, to get to your questions, though, there were obviously meetings with the administrative team and the board. We had a number of meetings for really about a 6 week period. When we were set on what our restructure strategy was going to be, and we had the date, September 9th. I went a few days before down and met with the county commissioners here in St. Genevieve County, and I just shared, look, this is fixing to happen. This is why, this is how the decision was made. And then the day we actually had the restructuring, I had already prepared the press release statement.
Yep.
We set it up to where there was going to be a meeting of all managers and directors, and immediately followed by meeting with the two departments of labor and delivery and of home health in this particular case. As I'm having the meeting with the managers and directors and walking through the restructure plan with them and why we're doing this, one of the administrative team was releasing the press release statement to the public at the same time. We're having that conversation with the managers and directors, and immediately after that, we pulled the home health director and the labor and delivery director aside, and we started meeting with staff. So that was really, that all occurred in a pretty tight timeline, is how we did that.
Yeah.
I think the press release did what we needed it to do. We explained to the community what we were doing and why. And it does seem to have been received pretty well. There was, for about a day and a half, quite a bit of you know concern and emotional concerns that were expressed, but then it just settled down, and it wasn't something we were dealing with a month later, much less 3, 4, 5, 6 months
Yeah.
later. When you take the time to comprehensively explain to people, this is why the decision was made. I think some of my peers over the years, I've seen them make decisions and they just simply say, here's what we're doing, here's the date, and they don't take the time to use the single biggest, I think, tool in your tool belt as a hospital administrator, and that is taking the time to explain why.
Yeah.
Why are we doing this?
Yeah.
Why will get you so far down the road without all the turbulence.
Yeah. Well, I got a chance to take a look. I mean, the public letter you're referring to, I mean, it framed everything that was going on with the restructuring to strengthen the hospital, not really retreat from the mission. And so when you talk about really, I don't want to call it fallout, but just the communication back from the community lasting a few days, and really, I mean, it sounds as though things have calmed for the most part over the coming months, but I'd love to know if, I assume that framing was very deliberate. You
Absolutely.
took the time to explain why the decisions were being made, but how do you strike a balance between honesty around hard cuts that have to take place, while also instilling confidence in the future, right? In your community, but with your staff.
Yeah. I think the honesty does instill the confidence. And let me give you a specific example there. I arrived at this hospital June 23rd. And when I'm meeting with the managers and the directors, they know very clearly the hospital's been struggling financially for about 2.5 years. All they've been hearing month after month at managers meetings is, well, we lost money again last month, and we lost a lot of money, or we lost some money, but we lost money. They had never been told what that amount was from month to month.
Right.
I came in. It was probably a little bit shocking, but I came in and started putting those numbers in front of everybody's face. Here's how much money we lost last month, And we cannot continue to do this. If we do, here's the timeline we're looking at. Here's what we're going to do about it. I would start off every meeting with, here was the financial impact last month. I will share with you that in January, when we started making money, that first meeting, well, we only have one director meeting a month, but the managers and directors sitting in there. Again, at this point in time, they've been through almost 3 years of loss, loss, loss. And I said, I want to congratulate y'all. You know, the work you have done has really paid off. And in fact, while it wasn't a huge margin, we actually had a net positive month in January. And there was no emotion. I mean, there was, it looked like soldier, video and photos I've seen of soldiers who have been in combat that are just in a bit of a state of shock. Now, in February we made money, and the manager started to lighten up a little bit. March we made money, and by April, very different. A very different feel to the culture. The managers were relaxed. They were joking with each other. They were feeling good. I mean, going back to your question, I think the honesty is what really shores it up.
Yeah. Well, I mean that much is on, and seeing the results, right? I mean,
Yeah,
seeing the results of what, was an initiative that had promise and now delivered. So I want to talk a little bit. You mentioned, staffing, of course, being a challenge financially, just given everything that's happened post COVID, right? In certain areas of hospital recruiting, but it's its own challenge, right? Away from the metro area, especially in rural areas. So for some of your peers who fight that same battle, right, with attraction, recruitment, what makes recruiting and keeping clinical talent so much harder in a rural market?
you simply don't have the depth, the local depth on the bench, so to speak. And I'll use nuclear med techs by example. If you go up to St. Louis, can you find enough nuclear med techs to really spread around right now to all the hospitals in St. Louis? The answer is probably, but only barely. How many nuclear med techs live in St. Genevieve County or any other rural county in the
Right.
nation? Usually there's not a full potential contingent of RNs that are even living in these rural counties, much less some of these specialties like registered dietitian, nuke med techs, et cetera, et cetera. Um, so that in and of itself is the challenge. You simply don't have the local depth on the bench, and there are some roles, more often than not, you have to either A, reach outside of your primary service area and try to pull somebody in, or B, and it's a strategy I like, it's not a short-term strategy, but identify someone that's in the organization already. In case in point, individual in diagnostic imaging in another discipline. Hey, do you have any interest in this particular discipline? Well, yes, I do, but it takes time and money to do that. Well, I'll tell you what, we'll enter into a contractual arrangement with you where we'll pay for your education. We'll help fund your time to go get that education, but you have a commitment to us for a period of time after
Right.
this is done. I think we've got three of those arrangements in process right now, and I've used them in other areas as well. But now again, that's not a short-term solution. But I'm just sitting there thinking, how can I help stabilize the organization's recruiting efforts, in 3 or 5 years?
Right. Well, it's hard. I mean, again, you have someone who lives in the community, who has probably a family there, has friends. I mean,
Yeah,
it's easier to grow. We call them grow your own programs, right? I mean, where
absolutely,
possible. Um,
absolutely.
you've got. I mean, we alluded to it earlier, but I mean, a real track record. It's just sticking on staffing or retention, but a real track record around that. I mean, in your prior leadership role, right? You cut voluntary turnover from over 25% to just under 9% in a single year. And we talked a little bit about, culture and the way you interact with your staff, but that's only one piece, right? I mean, what do you think actually moved that number outside of that or alongside that, and how much of it translates to a rural hospital?
So what I think really moves that number comes down to listening. It's not just being available. It's not just having an open door policy. It's being approachable and listening, particularly listening to the things that as a CEO you may not want to hear. I'm not happy. This is going wrong. We need to improve this. I've met some of my peers over the years that are not as receptive when someone challenges their
Right.
preconceptions, so to speak. You've got to listen. You've got to give the employees in the organization time to really give you the feedback. They're giving you a gift. I mean, how are you going to fix the problems if you don't really know
I
what
know
they
what they
are?
are. Right.
Yeah, and so I see it every time an employee approaches me and has something concerning to talk about. I see that as a gift that they're giving me.
Right.
Here's an opportunity for us to address something. And sometimes Brendan, I'm sorry, it simply needs to be addressed with information. It's not anything that even needs to be changed. It really comes down to let me give you the information you need to understand. It gets back to what I said a while ago. One of the biggest tools you've got in your tool belt is why. Explain why we're doing it this way. Explain why it has to be this way. But just as often, it is something that needs to be addressed or changed. And when you do change course because of something that an employee brought up, you've got to make sure you go back and give that employee accolades in front of
Yeah.
their peers. That, hey, I want to thank you for, I'm making this name up. I want to thank Tammy, the nurse in the ER, who brought this to our attention. And because of this, we've looked into it, and this is what we're
Yep.
doing about it
And
now.
there's the culture piece. There's the part where
Yes.
you round that full circle and folks understand, well, I can, this is a safe spot. To your comment earlier about when you were walking through the halls and the CEO never did that, right? I mean, it's
Yeah.
changing, how you're viewed within the organization in terms of being approachable and so forth. I mean, have you ever done, what's your philosophy around surveys? I mean, when you talk about getting a feedback loop, I always love to ask that question just to see.
So I'm huge on third party independent surveys. I'm not big on internal self-created surveys at all. Third party independent surveys I'm huge on. Now, I will tell you, if you go back 20 years ago, do I think you could have done one of those surveys maybe every 2 or 3 years? The answer is yes. Do I think you can do those surveys every 2 or 3 years now? Absolutely not. I think you have to do them year over year because you're not going to keep your baseline. Here's what I mean by that. Let's talk about pre-COVID and post-COVID again. If you go back to let's say go back 15 years ago, when turnover in healthcare could be managed at that 8 to 12% level pretty easily. Well, now let's be quite frank. Turnover, the baseline for turnover in healthcare, as I currently understand it, is 18 to 20%. So if you skip a year, even if it's 18%, if you skip a year and you just try to do that employee survey every 2 years,
You're missing.
36% of your staff may be gone. That's not a baseline. That's a new survey. So I think these days that if you're going to do it, I would say first of all I'm a big fan of them, but make sure it's a third party, independent, outside the organization. And I just think because of where the baseline turnover in healthcare is at the moment, you're going to have to do them every single year, or else you're not going to be able to say, well, here's what we were in 2025 and here's what we were in 2027 because you've got a very different staff.
Right. Well, yeah, it could be a completely different result, right? I mean,
Ab-
you talk about retention, recruitment, the turnover. I mean, my mind kind of goes back to compensation, right? And competing against bigger systems, and you've mentioned travel agencies when margins are much thinner than other organizations. Now, right now, I want to say that with the caveat that there's always a draw for a lot of individuals. I include myself in that mix, having lived in rural, Missouri for most of my life up to this point. There's a draw to being there, right? And so, I mean, there are different inherent other than cost, but in the society we live on, it's always it's going to be of paramount importance. So, what's your philosophy kind of on how you guys compete against those larger systems and travel agencies, given what you have?
when it comes to the travel agencies, we really aren't in a position to compete with them for the most part. If you got a individual that's willing to be gone for weeks at a time and to travel for months or years at a time. If they're in a place where their life where they can do that, it's very hard to compete with that. We do try to compete with the larger organizations that are within our general service area reach, if you will. Can I compete with? And let me give you an example. I have an ER nurse, and she says, "Hey, Steve, I can go up to this ER in the St. Louis area and I make $5 an hour more than I'm making now. You know, I need you to pay me $5 an hour more to do that." And I said, "Well, I can't do that. We can certainly look at it and see where we might can move your pay somewhat, but can I give you an extra $5 an hour?" The answer is no. Well, then that's where we are. I said, well, a couple of things to consider. One, you're talking about adding each day you go to work anywhere from 45 minutes to an hour one-way drive. So you're going to lose an hour and a half to 2 hours each work day of your current life, as opposed to living maybe 10 miles from where you work right now. And two, you're going to go from an ER that sees 16 patients a day to one that maybe sees 116 or more patients a day. That's a very, very different work environment. I personally, in my background, have worked in one of those ERs where you were seeing that the ER was seeing 100 patients a day. That's a very different work environment. So, you try to have those conversations and you try to work with them. You have to stay competitive. You have to stay what I call market competitive. But at $3.50, $4 a gallon gas driving, am I going to match what they're paying when your gas bill just increased several $100s a year or more? So there's conversations you can have with the staff, and we certainly try to have those conversations. Most of the time, I think we're successful. Sometimes we're not.
Yeah.
We have had since I have been here, we've had two nurses that have left. One of them was a nurse practitioner that left and went for the bigger and better. Got tired of the travel time, got tired of the traffic, got tired of the workload, and they've both come back to us and said, "You know what? The grass was not greener on the
Right.
other side." Yeah,
And I bet that
yeah,
happens more often than, well, I will say more often than not, but quite often.
yeah.
So well, I want to, I mean,
We
I've appreciated your perspective really on staffing, retention, kind of employee culture. I want to shift to kind of the patient experience, which is really what it's all about, what it's all geared to. And I mean, I heard from Nate Blackford, right, at MHA that you shared, a great perspective recently on healthcare consumerism, which we talked a little bit about. So I'd love to start there. I mean, when you look at today's patient as a consumer of healthcare, which again, in my business, we talk about all the time, trying to make patients better consumers, better understand, giving all the opaqueness, right, of that's out there. What from your perspective, what are they looking for, and how is that different from just a few years ago?
so if you think about what is it patients really want, it's easy to get caught in the trap of, well, they want quality and they want safety. And I will argue that point. Now, you'll have to hear me out through the whole piece here, because it's going to sound like I'm saying quality and safety is not important. That's not what I'm saying at all. Quality and safety is infinitely important. But think of it in this context. When you go buy a new vehicle, you probably expect it to come with tires. You don't buy a new vehicle and then try to negotiate or want the tires. You just expect that's going to be part of the package deal. I fully believe that patients today expect quality and safety. I expect, Steve, that you're going to provide me with quality health care and you're going to keep me safe while you're doing it. Just like I expect when I buy a new car, I'm going to get tires with it. So what do I think it is that the consumer, the patient, is really wanting in this day and age? I think they want convenience.
Yep.
I think they want somebody to answer the phone when they try to call us. I think when they get here, they don't want to have to wait an exorbitant amount of time. I think they want to be able to access getting their medications refilled or making appointments or moving their appointment or paying their bills from their cell phone.
Yep.
One of the things I challenge when I talk to some of my peers about this, and some of them start pushing back about, no, quality and safety is all that matters. Again, quality and safety is infinitely important. I just think the patients expect that. I don't think they wake
Right.
up and say, you know what I want? I want quality and safety. I think they wake up and say, I want convenience. And
Right.
what I challenge when I'm having conversations with people and we're debating this, I say, let me ask you a question. Have you ever been at a drive-through of whether it's a Wendy's or a Burger King, it doesn't matter what it is, and see people drive out of the line because the line's not moving fast enough?
Yeah.
Absolutely. And then I'll ask them, have any of you ever done that? And I've had several people say, well, yeah, I've actually done that. Your patients are doing the same thing.
Yeah.
Make it easy for your patients to do business with you.
Right.
It's one of my first standing directive that the staff here learned is, matter of fact, I used that. We had an email just about 2 weeks ago, Brendan, and email was going back and forth between a manager and a director in surgery. Had to do with a physician's office. The surgeon's office is wanting additional to move a day, and it was creating a little bit of angst among these three different directors. I was copied on these emails that were going back and forth, and it went back and forth for about 10 or 15 minutes. And then I just replied to all, and my email simply said, make it easy for your customer to do business with you. In this case, I was talking about the surgeons. Um, and lo and behold, within about 10, 15 minutes, email came out, problem solved. I mean, sometimes you just have to focus people on the basics, so to speak.
Yeah.
Does that make sense?
Yeah, I mean it always it seems easy. Sometimes I'm sure it's not as straightforward. I mean, when I think about everything you've just said, I think about all the other industries out there, right? I mean, you want same day. Consumers just want same day everything, price up front,
Yep.
book it from my phone. And so when I think about what the core of that is, which is just efficiency, right? You're bringing efficiencies that allow you to do all these things more quickly and be more user friendly and consumer friendly. I think of spending and a rural health system spending on technology and making investment or technology as a piece of that puzzle. And so my question to you is kind of twofold. What are you seeing as being super important? And we'll get to AI, but I mean, just technology on the forefront and where are you seeing, investments likely to be made given, again, the tight margins and everything we've talked about that's just inherent in rural health?
Yeah. I'm sure before I say this, I'm sure just like we're a rural health hospital that has a cancer program, there's always these kind of one-offs. I'm sure out there somewhere there's rural health hospital or hospitals in the nation that maybe have robots in their surgery department.
Mm.
But those would be the in my mind one-off exceptions to the rule. So when I think of technology and I'm having conversations with my rural health peers and they say, well, we can't afford that. I agree with you. Are you ever going to have Da Vinci robots or other newer robotic augmentation in your surgery department as a rural health hospital? The answer is probably never. Do you really have a choice though when it comes to investing in things to make it more convenient for your patient to do business with you, whether it is setting up infrastructure so that they can access from their cell phone. Again, I can make an appointment, I can move my appointment, I can request a refill, I can pay my bill. I really don't think in this day and age you have a choice but to invest in that because if you don't make it easy for your patients to do business with you, they're going to go do business with somebody that does. I just firmly believe that.
Yeah.
And some of these technologies that I'm talking about are actually not that expensive when you compare it to something like the robot augmentation in surgery departments, which we'll never do.
Yeah. Well, I mean, it sounds just listening to you talk about this. I mean, I'm hearing nuggets of long-term investment where we're looking over, which is your job as a CEO, right? I mean, not just look at what we need now, but the investments and priorities over the long term. But I mean, where does the consumer experience take rural healthcare over the next 5 years, right? To stay on track, to stay relevant in a consumer market like you're talking about against your, if you want to call them competitors, right?
So, so the patient experience in rural healthcare is the future of rural healthcare. And I say that, let me point you to about 10 years ago, PricewaterhouseCoopers released a white paper. Their healthcare think tank had gotten together and said, "Hey, we think basically about 10 years ago, there's really four paths forward for healthcare organizations to be successful. in what we see lining out. Now, 10 years ago was before COVID. Do I think COVID changed any of this? The answer is no. But what those four things were that PricewaterhouseCoopers white paper came up with was one, you can be an entity of vast scale and scope. Well, rural healthcare, you're not going to be, vast scale and scope doesn't apply to you unless you're a rural healthcare organization that is affiliated with a big organization. If you're a rural independent, your vast scale and scope will never ever apply to you. Don't waste your limited time, attention, and energy on something you'll never be able to achieve. Another one was you can be a technology innovator. Well, rural healthcare again with the margins. Are we going to wind up with surgery augmentation robots in our surgery departments? The answer is no. We're trying to keep CRNAs here so that we can even do a few surgeries, so to speak, for a lot of rural hospitals in this day and age. Or you can be a specialty hospital. Here, what I think of when I read that paper, I think of St. Jude's down in Memphis, Tennessee, the Children's Hospital. There's a hospital that has a very specific focus on a particular patient population. There's women's hospitals out there across the nation as well. Are you a rural hospital that you're going to do that? The answer is no. Or the fourth way that PricewaterhouseCoopers said we think is a path forward to be successful is you have to have the relationship so that you are seen providing basically exemplary customer service. You will develop relationships with patients and patient family members by providing them with personalized service at a level beyond anywhere else. And do I think we can do that as a real hospital when you compare it to one of the big Mercy, BJC, even SSM hospitals? And by the way, I have good relationships with them. I'm not picking on them, but here's the reality of it. You come into my 25-bed critical access hospital, and in your community, you're not the patient in room 317. You're somebody's neighbor or mom or sister, and we're going to treat you that way.
Right.
And we can provide you with a level of personal service that a 500 bed hospital will never ever even come close to achieving.
Yeah.
I think that is the successful path for rural hospitals.
Yeah. So it's important. I mean, that's beautiful here. You outline it that way. I'd be curious, taking it a step further, if that's the attraction, if that's the cornerstone, right? I mean, to driving consumerism there in your local hospital. How do you effectively market that, right? Is there a part of your strategy that really taps into that, whether it's public relations, whether it's foundation work, whether it's just a billboard that talks about care close to home, right? I mean, how important is an effective marketing strategy, even as a rural hospital where everyone in the community knows who you are? It's about controlling the narrative of what you get.
It is, but I don't think actually it's about a marketing strategy. It is part
Yeah.
of a strategy, but it's not a marketing strategy. You have to live it, and the patients have to experience it. It really comes down to the patient's experience. That's what's going to drive it. I have a good experience.
I'm going to tell
I'm going to
others.
go talk about it. I'm
Yep.
I'm going to come back and be a repeat business. I'm going to bring my family here and refer my friends here. You have a bad experience.
Right.
And we know how that works as well. So do I think you have to market it, so to speak? No, but how do I address it? So one of the first things I did when I came in here, I had every individual that's employed here go through. It's an hour and 15-minute long customer service 101 is what I call it. It's a program that I put together back in 2006. I've been using it ever since because it's benefited the organizations I've worked in. And it really sets the tone. It explains what, from the patient's perspective, is really important. And more importantly, it explains to the staff what the patients and the patients' families are judging you on. And they are not, by the way, judging you on the clinical care at all. It is something very different, something much more fundamental. And that's a conversation for another time. But I walk through. I bring everybody in the organization. We run through this, and then how important is it? So every new that same presentation to really set the tone from the day you first set foot in here as a new employee. This is what we expect. This is how we expect we will conduct ourselves towards the patients, and this is what's important to
Right.
us. And it really sets the tone. And then as leadership, you've got to walk the walk and not just talk the talk. You have to demonstrate it from the top down what is important in how we conduct ourselves. If you don't have time to listen to your staff as a CEO, if you don't take time, when I say don't listen to them, you don't hear what they're saying, or you're standoffish, you're not approachable. Well, guess what? You're sending a signal to your staff that says
Right.
this is an acceptable way to behave. Well, who are they working with? They're working with the patients.
Mm.
It's a top-down trickle effect. I firmly believe that.
Yeah. Well, you certainly set the precedent, and just even early on in our conversation, how you interact with your staff and how it does trickle into everything else that the patient experience, right? I want to stay on, I mean, just investments, technology. I alluded to AI. I'd be really curious. You kind of flagged it as something that's on your radar. I mean, for a hospital your size, where do you realistically see AI earning its keep, or is there just a hype that's outrunning what the real reality of the impact is going to be?
So let me start off by saying, is AI perfect? No. Is AI always correct? No. Let me also share this with you. Are people perfect? No. Are people always correct? No. So let's just get that out of the way first. Now, where we are going personally with AI, we will have ambient listening live in all of our clinic exam rooms by the end of this calendar year. We'll be rolling it out to the ER shortly thereafter. We are also moving in tandem with that, getting AI augmented coding. And so these are the first steps that we are doing here personally. And the only reason why we're not doing this right now today is because we're in the process of changing out our radiology group,
Hmm.
which is a heavy lift on its own for the IT department. So what I said is, as soon as we get that new radiology group in place, which will be September 1st, and we get the little bumps that are worked out, because anytime you do a heavy lift like that, there's going to be some wrinkles you have to work out. As soon as we get that stable, we hard charge ambient listening. We get it in the exam rooms. We get the training done, and we're live with it across the board no later than January 1st. And the reason why I'm after ambient listening in the exam rooms is one, I think it's going to make it infinitely easier on my clinicians' work days. The doctors and the advanced practice providers, I think it's going to make their life easier. We've got two clinicians that are using that right now, using pilots. And when you see their documentation before ambient
Mm.
listening and their documentation after, it's not even daylight and dark, Brendan. It is light years difference. And so I'm after this for twofolds. One, I want to make the work life of our medical staff better. I want to make their experience better, and I believe this is going to happen. The feedback that the medical staff has given me from the demos they've seen for the last, 6 weeks is, oh my God, can we get this
Right.
tomorrow? This is going to be
Right.
great. But the other piece I want is I want that augmented coding to go with it, because if a just hypothetically, if a Blue Cross Blue Shield or a United or an Aetna or even ultimately a CMS is using AI to look at
Right.
our claims and decide whether or not they're going to pay or to what extent, I'm just going to be real frank with you. I can't fight that with coders named Carol or Tammy or Ron.
Right.
It's that's a very one-sided fight. So I don't see that there's an option here but to pursue this for that very reason. If
Right.
you're if the insurance entities are going to use AI against us, and some of them already are,
Right.
um, we can't fight that. I look at it. This is an analogy I would use. Maybe it's not a great analogy, but I look at it as we're a country without nuclear power, so to speak, fighting countries that have nuclear
Right.
power. It's a pretty one-sided fight. Now, I say all that to say this. Philosophically, I don't think there's an option here. We have to move this direction because the people that we are working with or in tension with are already doing it. Do I philosophically think that to a certain degree, we're children playing with something that we don't fully understand? The answer is yes. And I go back to, the early 1950s and nuclear energy. But before we
Mm.
realized that it did more than just make a big boom, oh, by the way, there's something invisible that actually kills people
Yeah.
and poisons them over time. I think downstream, we're going to realize that AI was much more than we thought it was ultimately.
Yeah.
Is
But
it
I mean,
perfect yet today? The answer is no. But do I think it's going to be a paradigm shift, not unlike nuclear energy was back in the late or mid 40s?
yeah. But again,
I really think generations from now will look back and go, wow, they did not understand what they were doing.
what were they thinking? What
Yeah.
and the amount of
But
times I've heard
again,
that.
yeah, but again, there's from my perspective, there's a little bit of an arms race right now.
Right.
When the people I'm sending our bills to are looking at this with AI, that can get into the nth degree of
Right.
detail in a matter of moments. I just can't fight that with people that I have to keep up to speed month after month, year after
Yeah.
year on what the codes and what the buzzwords are today. Now, don't get me wrong. Do I think AI is going to come in here and completely replace everybody that doesn't touch patients, so to speak, that doesn't have a physical presence with the patient? The answer is no. Is it going to replace some jobs? The answer is absolutely yes, I believe. But what it's also going to do is it's going to create the need for analyst level jobs that don't currently exist. So we've got coders right now. When we have AI doing a lot of the coding for us, we'll still have to have analyst coders who are trained to really look over the shoulder, if you'll allow me to use the word overread it, to make sure that AI is doing what it's supposed to do. Probably what they'll be doing is spot checks, unless they find something, and then they'll
Right.
do a deep dive. So I think AI is going to create a whole host of analyst level jobs in hospitals that don't currently exist today. But if it's basically, and I'm not meaning to marginalize anybody that's a coder out there, they do incredibly important work. But if you're basically entering data, do I think AI is going to replace those jobs? Yeah, I
Yeah.
do.
Well, again, you're dealing with it's the David versus Goliath effect, right? I mean, you're dealing with
Absolutely.
these payers that, let's face it, they were already playing some of these games, right? Down coding claims when you're trying to upcode claim or get claims to parity, pay you the dollar you're owed, denying claims. This is just hyper fueling their ability to we call it play those games, right? And that's
Yeah.
not even words I've used. That's just from other healthcare administrators, right? I mean, we all know that, and so you do. You've got to get on that level and create parity. And honestly, I'm sure this is a way to create that, maybe even more in a greater way than you would have ever had before. Um,
Absolutely.
so tell me a little bit about. I mean, we're talking about AI and technology when we think of rural health, and I mean, especially the service lines that are available at a rural hospital. I mean, telemedicine has been one of the main ways that small hospitals extend access. Do you feel like AI is kind of the next version of that? You've talked about it creating new jobs and analyst roles that can maybe help you combat payers and look at contracts more effectively. And when you don't have teams of attorneys to do that, although I'm sure that's something that you bring to the table yourself. But what do you feel like it is kind of the next version of that?
Absolutely, I do. And I can give you a specific personal example here in just a moment. I firmly believe that in the future, there will be clinicians that are augmented with AI, and there will be healthcare organizations that are augmented with AI, and they will be successful. And the clinicians and the health organizations that do not choose to augment themselves with I just don't think they're going to be able to play in the what is coming as a paradigm shift. I firmly believe in healthcare. I just don't think they're going to be able to keep pace at all. So from my perspective, you hard charge it. Now, let me give you a very specific example of where AI personally gives a peek into the future. I am not, by the way, recommending anybody do this. I'm just sharing with you a personal experience. So before I came here, for a year before I came here, I had a spot up here on my right shoulder that looked suspect to me. I had seen not one, but two doctors in another state about this spot over the course of a year before coming here. One of them said, it really is not anything, Steve. I wouldn't worry about it. We'll just keep an eye on it. And another one said, it looks like a burn to me. Well, doctor, I would know if I got burned, and it's not a
Right.
burn. It just appeared, and it's been very slowly over time getting bigger. I think this is suspect. Yeah, I really don't think it's anything to worry about. So I show up here. I haven't been here long at all. Matter of fact, I think I've been here about a month. I've already established myself with a PCP here. I did not mention anything about this. I found an extra 5 minutes in my life one afternoon at home. And so I just happened to type in what I had seen and what I was describing to an AI engine. And it came back pretty quickly and it said, what you're describing could be one of these 7 things, one of which was basal cell carcinoma. Now, it had basal cell carcinoma listed at number one in that line of 7 things, but then it said, if you would upload a photo,
Picture. Yep.
I might could narrow this down a little bit more for you. So I take my cell phone, I reverse the image, I take a picture of it, I upload it into this AI system, and very quickly it comes back. Again, it was qualifying itself, this is not medical advice, blah, blah,
Right.
blah. But it said, while it could be, now instead of 7 things, one of these, maybe 3 things, this does appear to be a basal cell carcinoma. I recommend you go to a provider and have a
Right.
biopsy performed. So the next day, I call and I make an appointment with my PCP. I did not tell her any of this, by the way. So I go in there and I make an appointment with my PCP, and I said, "Hey, I do have a spot right here. It appeared a little over a year ago. I think it's suspect." To her credit, she looks at it. She says, and she listed 4 things. I think, Steve, it could be one of these 4 things, including one of them, basal cell carcinoma. Just to be sure, I'm going to take a biopsy and we're going to look at this. Biopsy came back basal cell carcinoma.
Oh my gosh.
ChatGPT did in 5 minutes what 2 doctors in another state couldn't do in a year. Now, that I'm not recommending anybody does that.
Sure.
Um, but that's a glimpse of where I think the future will be. Now, you marry that type of capability with a trained, licensed physician and his or her mind. What you've just done, from my perspective, is you've taken that physician and you've just added a ton of horsepower to
Yeah.
them.
Yeah.
So I think in the future, AI augmented physicians are going to be really a great thing.
You talk about marrying that capability. I married a dermatology physician assistant, so I don't have to worry about AI coming to the forefront on that. I got it right
Yeah,
here at home, brother. But I
there
mean,
you
that
go.
is that
Yeah.
is a very unique perspective. And again, when I think of just medical literacy and being able to identify things, I mean, of course, you can't recommend that, but it's going
Yeah.
on, right? If you're doing it, I mean, folks that, eh, you know, aren't don't have the ability to go in, or maybe when we talk about access to care and timeliness to be seen, I mean, it's got to have some inherent benefits, right? And so
Absolutely.
I'm kind of excited to see what where that how that unfolds as well. But when we talk about even, let's zoom out 30,000 feet. We've been talking about a lot of microcosms, but if you could change one thing about how this country funds or thinks about rural health care, what would it be? And I mean for this to be maybe even a policy question, but also just, your thoughts on how it might need to change.
So I personally think healthcare, and before I say this, I'm not pushing socialized medicine here at all. So I don't want anybody to mistake this next comment. But I personally don't think healthcare should be for profit. I don't think investors should make a profit off of your cancer, your heart attack, your stroke, your car wrecks. Um, and I really stop at that point. Am I pushing for a one payer healthcare system in the nation? No, I'm not paying. I'm not pushing for that at all. But I personally have some heartburn with for-profit healthcare, just the concept in general.
Yeah. Yeah. Well,
And
there's a lot.
so,
Yeah.
yeah, I just think if I could have one policy change at the national level, it would say, healthcare needs to be a not-for-profit entity.
Yeah. Well, that's such a loaded topic, and
I know, right?
I mean, I'm sure we
And
could go ad nauseum about, the reason socialized medicine works in other countries and how it works so well. And some make the argument that it works well there because it doesn't here, right? And the
yeah,
capitalism involved in some areas of healthcare, right? I mean, and not necessarily in for-profit health systems like you're talking about. When I think of more pharma and some of the innovation that takes place, it's a
yeah.
delicate balance, right? Of
It is, and I don't want anybody to mistake what I just said.
sure,
I wasn't taking a shot at the quality or safety of for-profit healthcare. I've been part of conversations with some people that work in for-profit healthcare, and they have very great, from a quality and safety standpoint, outcomes and organizations. It's just philosophically, when you ask me that question, and you've probably figured out by now, I'm not one to shy away from hard questions. Most of my peers would probably say, "Yeah, I'm not going to touch that." I just philosophically think that it does not have a place as far as investors profiting from your cancer, your heart attack, your
yep.
strokes.
No, uh, I love the ideology there. I mean, so let's shift it back down to from 30,000 foot to right in front of us. I mean, I've enjoyed this conversation, Steve. Your perspective is invaluable, and I've loved all the examples you've paired with your thoughts on the subject. But I mean, what's one mindset shift you believe rural healthcare leadership needs right now, and tell us what's something a rural healthcare leader listening can take action on this month.
So stop thinking that because this is how it's always been done, and this is how we've always done it, and this is what we've always provided, therefore we're always going to do this or else. Get out of that mindset. I mean, and again, I'll give you an example here. I'm old enough that I remember when healthcare was delivered at rural hospital levels, your PCPs in town would show up in the morning and make rounds on their patients that were in the hospital. They might do a couple of low-level procedures in surgery before they start their clinic day. During their clinic day, in the middle of the morning, they'd get called to come to the ER and treat one of their patients who came in for an ER visit and go back to their clinic. Middle of the afternoon, they might get called back to the hospital, come in and deliver a baby, and then go back to their clinic. And when they finish their clinic day at 5:30, 6 o'clock, they come back to the hospital one more time to make rounds before trying to tuck their patients in, and then they go home and be on call. Well, those physicians don't exist anymore. And so when you talk about, well, for 50 years we had labor and delivery. Well, your primary care physicians were probably doing it, and
Right.
then you had to transition to OB physicians. Well, then you had a new generation of physicians coming out, and I'm not belittling these guys and girls at all who want a much different work-life balance. I hold in awe some of the older physicians who mostly don't
Right.
exist anymore because I never understood how they could work
Could do it.
a 16, 17-hour day after day, month after month, and year after year, but they did it. But that's not healthcare anymore. Healthcare anymore, I'm interviewing doctors right now, primary care physicians. Here's the common denominator. Look, I want to work 4 days a week. I don't want to take any call. I want to make this much money. Um, and I don't begrudge them at all. I think it's good that they're finding that work-life balance. But what I just said is if you're going to have some of these services, maybe in the past you could have a one-person show for surgery.
Yep.
Well, now one surgeon's not going to get it, and two's not going to cover all of your call. You're going to need three, or you're going to have to support them with locums. Well, guess what? You can't afford
Mm.
that. Same thing with OB docs. One's probably not going to be a one-person show. Two won't cover all the call. You'll have to supplement with locums, which gets really expensive really quick,
Yep.
or you're going to have three, which you can't afford.
Yep.
You've got to be willing to step back and say, look, I understand how we've always done it. But healthcare has changed. The environment has changed. The workforce has changed. Don't drive yourself into the ground
Right.
trying to hold status quo.
Yeah.
Take a hard, objective look and be willing to make the hard decisions when you have to. I would rather personally have come into an organization of 440 people and devastating as it is to the individuals and the families. Absolutely, I get that. But I would rather lose 40 people and have 400 to continue being employed and to provide cancer services and surgery services and all these other services that we can, than to continue the organization for 2 or 3 more years down the road and all of a sudden wind up one day and you can't make payroll.
Right.
You've got you've just got to be willing to take a step back, take an objective look, and be willing to make a hard decision
Yep.
when you have to. Now, if at all possible you can find ways around it, by all means.
Yep. Being strategic around service lines is just something. I mean, not that that's the only core point you touched on, but it's just something that every hospital is looking at now for a lot of those same reasons: staffing, capacity, expertise, safety, and quality. Right? I mean, being able to keep up with that. And so, no, I mean, Steve, this has been great. I really appreciate you coming on the program, and I know the viewers are going to get, they're going to love your perspective on everything we've touched on today. So thank you so much for taking the time.
Brendan, thanks for having me. I hope you have a great day, and I look forward to the day you stop by sometime.
It'll be sooner rather than later.
All right.
All right, Steve.
Have a good day.